My name is Kathleen Hoagland, and I'm the Program Representative Supervisor in the Division of Program Support and Quality Improvement at DDAP, and we have started recording this call. So if you are not comfortable with that, please exit the call right now, and you can access this the content from what we're going to be reviewing today at a later date on our ASAM transition website. So again, thank you so much for joining us. This is being recorded. Just a couple of reminders. So for these calls, and many of you have been on all of these calls, which is fantastic, you'll know that we ask you all to submit questions on the topic 7 days in advance to the ASAM RA email account. And if you want to submit a question today in the chat, you can also do that. We will have some time at the end of our meeting today to review a couple of questions. We'd like to stick to the topic at hand. So today we're going to be talking about staffing. So please feel free to kind of enter your questions in the chat, and we'll keep track of those as we're going along, and we'll follow up with those at the end of the meeting today. Again, this call is being recorded, so please exit now if you're not comfortable being recorded. And if you have suggestions about future call topics, you can always submit those to the RA ASAM email account. We're always looking for future topic ideas. So please feel free to do that. And while we're going to be talking about the topic of staffing today, we just want to make sure that everybody is aware and understands, and I think most people do at this point, that alignment with the ASAM criteria is required for drug and alcohol treatment providers that receive funding for providing treatment services under agreements with single county authorities and or managed care organizations. And the information that we're going to be presenting today is just an overview and a summary about staffing across the levels of care. So we really want to stress the importance of making sure that you're reviewing the ASAM text in its entirety, obviously that you're attending the ASAM 2-day trainings, and that you're looking at the resources available on the ASAM transition website. So just remember today, this is really just a snapshot and it's a glimpse. And we, in order to really understand everything that we're going to be talking about, you have to kind of make sure that you're looking at the whole picture of ASAM criteria. Okay, so I think we're going to start today that, we're going to be talking a little bit about staffing, like I said, but before we dig into that, I do want to give everybody an update on the ASAM alignment reviews. So I know that many people are wondering kind of what this process is going to look like. And when I say ASAM alignment reviews, what I mean by that is the process by which DDAP and DHS and the MCOs and the SCAs are going to be coming on site to providers to review really how well they're delivering services in alignment with the ASAM criteria 2013 edition. So just want to give an update today on where we're at with that, because I know a lot of people have questions about this. Again, the alignment reviews are going to be a joint process in terms of who's going to be involved. It's going to be, again, DDAP, it's going to be DHS, it's going to be the MCOs and the SCAs. And what it's going to look like is it's going to look like basically we're going to be asking providers to submit policies and procedures, maybe daily program schedules, staffing charts, job descriptions, training logs, and other documents to DDAP. And this also will include obviously chart reviews. So there will be a group kind of coming on site to providers, and they will be interviewing providers. And so before anybody kind of panics, I just want to explain how this is going to roll out, what this is going to look like. So the plan for alignment reviews right now is this. So DDAP, DHS, MCOs, and SCAs are all working together to facilitate a pilot ASAM alignment review. And this pilot ASAM alignment review, and this is pilot number 1, which you can see on the screen here. This is going to be taking place at the end of June of 2022, so at the end of this month, actually. So this will be our first pilot, and it's going to take a little bit of time. And so really the purpose of this first pilot is to really gauge how well the alignment review tool we have created measures basically what it's supposed to measure. And to fine tune this alignment review process. So it's really, it's almost more so for, DDAP and DHS and the SCAs and the MCOs to make sure that the tool we're going to be using is working well and it's doing what it's supposed to be doing, and the entire process is in a position to really move forward with the other alignment reviews. So we also want to gauge, obviously, how long this process will take and work out any other issues that may be kind of arising. And we also want to give the provider who agreed to participate as our first pilot, we want to give them the opportunity to provide us feedback about that process in general, what it was like for them as a provider. And then obviously we'll be giving the provider feedback and providing technical assistance as appropriate. So the plan is, after we kind of complete this first phase, is to move on to phase 2, where we'll have 5 additional pilots using, hopefully at that point, a more refined process that has been established, learning what we've learned from the first pilot. And our hope is that all of these pilots will then kind of be complete by the end of fall of 2022. And in terms of next steps, what that would look like in terms of all the pilots after pilot 1 is that the MCOs will be reaching out to the SCAs in the next month or so in an effort to identify providers who are willing to participate in phase 2, so in those additional pilots. So again, that next step will include MCOs reaching out to the SCAs in the next month or so to identify providers who might be willing to participate in phase 2 of this pilot process. I realize that many of you may have questions about this, and you may have concerns, and so you're always, you can always submit those questions into the ASAM email account or even into the chat today. But I just want to again remind folks that this is a pilot, so we may not have the answers to your specific questions until we've completed at least pilot 1. And so we just ask for a little bit of patience, and you all have been extremely patient, and we really, really appreciate that. So again, if you do have questions today, please just keep that in mind, that this first pilot hasn't occurred yet, and we'll have more answers hopefully after that. But if you would like to today, you are more than welcome to submit some of those questions into the chat. All right, so moving on to the topic at hand today. So we're going to be talking about staffing across the levels of care, and we're going to kind of dig into each level of care and look at and discuss the staff that is necessary to have at that particular level of care. We are going to be pointing out specific parts of the text that are going to be helpful in gaining a better understanding of staffing across the levels of care. And on most sides, you're going to be seeing page references so that you'll know where to access a specific information in the text. If possible, and I know some of you may laugh at this, I do recommend, if you have your textbook available, your ASAM text, pull it out, follow along today. I know that's really, really helpful for me, and I think it can be helpful for others as well. And then we're going to be pointing out some definitions related to staffing that are going to be helpful, in addition to pointing out those page numbers. And then, third here, we hope that you can really start to see some common themes as it relates to staffing. And we realize that, like many other topics that we've discussed during these calls, you may have questions or concerns. You may have lingering, you just may not understand what we're trying to say, and that's okay. So we encourage you to put these into the chat along with your question, and our team will work together to respond to you. And again, we may have time today to respond to your questions at the end of the call. So I want to start this off today by just pointing out some important definitions that are in the ASAM text. And for those of you who have been on previous calls, you know that this is one of the things I really like to remind folks of, is that the definitions in the glossary in the back of the book is extremely, extremely helpful in kind of gaining clarity about certain topics. And so today we're going to be talking about staffing, obviously. So some of the definitions that I pulled out here are ones that we're going to be talking quite a bit about. So counselor, clinician, interdisciplinary team. Not going to read these off the slide for you. I would encourage you to kind of jot these down or take a look at these. But these are going to be pretty common words that are used throughout the presentation today. And in terms of the interdisciplinary team here at the bottom, I would just say that this is present in pretty much all levels of care. And so understanding what an interdisciplinary team is absolutely critical to the ASAM alignment process. And I think most people on this call here are part of an interdisciplinary team, and that, ASAM can't exist without that present. And so it's just a really critical definition to understand. And I just want to remind folks that as we're going through the call today, I am not going to be looking at the chat while I'm presenting. We do have a staff member who has graciously agreed to kind of keep track of the questions coming into the chat. And so I'll take a look at those as we wind up the presentation, and we can hopefully answer some of those at the end of the presentation today. So not ignoring you, just want to make sure that you understand that. Just not going to be answering those as I'm presenting the slides. And this other definition here, addiction credentialed physician, really wanted to bring this up, and I'm gonna use my highlighter today. So wanted to point this out because I know we've gotten a lot of questions about this specific definition as it appears in the ASAM text. A lot of people have been very concerned about the fact that, well, hey, listen, we don't have an addiction certified physician. Those are very hard to come by. It requires very specific training. There's a provider shortage, which has only been, even more impacted by the pandemic. And rest assured, I just wanted to make sure that people saw that in the ASAM text on page 411, there is a definition of addiction credentialed physician. And at the end of this definition, I think it's really important to pay attention to this. So it says, in situations where a certified addiction physician is not available, physicians treating addictions should have some specialty training and or experience in addiction medicine or addictions psychiatry. And if treating adolescents, experience in with adolescent medicine. So what this is essentially saying is that, hey, we recognize that there is a shortage of these physicians and that not everybody's going to have the resources or it's just not realistic for people to hire an addiction medicine physician, but a physician or a physician extender who has experience in addictions would suffice in that case. So just want to make sure that people kind of understood that. And this verbiage is also used throughout the ASAM text. ASAM acknowledges that there is a shortage. This is not going to be a reality for a lot of providers across the US. And so just something to kind of be mindful of as we're looking at that when that pops up today as we're reviewing the levels of care. All right, and before we kind of dig into each level of care, I did want to take a look at a chart that kind of lays out all the levels of care from level 1 to level 4. Because I think, through kind of putting this in one place, we can start to see some kind of common themes that come out. So here I listed the staff as mentioned, just verbatim as mentioned in the text on the left side. And then I listed each level of care. And I did this to kind of illustrate some strong themes. So first, again, just talked about this. We see that the term interdisciplinary team is used widely across the levels of care. We see that physicians with specialized training, like we just talked about, are also very common. And then certified and or licensed addiction counselors and social workers appear in almost every level of care. So, and then not surprisingly, kind of in those levels of care, more appropriate for individuals with significant medical or behavioral health needs, nurses are a key staffing component. And in the levels of care that require 24-hour staff and support, allied health staff are noted. So just thought it was kind of helpful here to lay things out like that. Also, before we dig into the specific levels of care, I just thought this was a good time to remind folks that when we're talking about staffing today, we are talking about it understanding that we're building off the previous topics that we've covered in these monthly calls. So again, I know a lot of the folks on the call today have been present for pretty much all the calls that we've had. So this is really going to ring true for you in particular. So we've talked about therapies, we've talked about support systems, we've talked about the importance of individualizing care for each and every patient. And as we look at each level of care, we're going to be talking about the minimum staffing required. So not every patient will need to see every staff required at that particular level of care. Care, again, is individualized. So the staff that the patient interacts with and the frequency at which they interact with this particular staff, this is going to look different for everyone based on their presenting issues, their request, many other factors. So just wanted to make sure that I reminded that, that I brought that up as a reminder today. Also, just want to remind you that, I'm not going to list this out on every slide today because it's really a given, but I just wanted to remind folks that the expectation with ASAM, and again, this is a previous topic that we discussed in these calls, the expectation is that all levels of care must be co-occurring capable. So again, I'm not going to go into kind of what that means in detail, but at the very general level, that means that the program staff is capable of monitoring, mental health symptoms, recognizing instability in patients who may have co-occurring symptoms or conditions. This means that folks with co-occurring symptoms, even if they don't have a diagnosis, are welcomed into the program. Staff knows how to interact with these folks. They know what to look out for. They know how to speak appropriately about mental health issues with patients. So that is really that, every single level of care in an ASAM aligned system is co-occurring capable. So just want to make sure that everybody remembers that today. Again, if you weren't here for the co-occurring capable phone call, we do have all of that content on our ASAM transition website. All right, just going to state this one last time. So remember today, as we're going through staffing, please remember the backdrop of the previous topics that we've talked about. So remember the therapies and the support systems that we've discussed, the co-occurring capability, the individualized care. So just we're kind of at this point in this series of calls, really trying to pull everything together as much as we can. So please just try to remember that. Okay, going into level 1, obviously our outpatient programs and the least intense level of care. So again, just want to remind folks that some of these positions, and I think this is probably the case for many of the outpatient programs in the Commonwealth, some of these positions are not actually on staff or they're not on site. So they may be available through consultation or by referral. But remember that they have to be available within the timeframes that are noted in the support system section of the text. So using this as an example here, for number 3, the addiction specialist physician, and remember what that also means if you don't have an addiction credentialed physician, that's a physician who has experience working in addictions. They must be available by consultation or referral within 24 hours by phone or in person as appropriate to the severity of the situation. So just kind of remember this in the context of the support systems. The bottom line here is that when we're talking about staffing, we are talking about it in the larger context of the ASAM book, the support systems, and we always need to be mindful, obviously, of licensing regulations that may come into play here as well when we're paying attention to timeframes and other requirements. So again, you see here that the certified or licensed addiction counselors are providing some of those 9 hours or less of the therapies noted in the ASAM text. Office-based nurses are providing just regular nursing care, but they also may be providing help with medication management. They are probably providing education about medications to improve treatment adherence and outcomes and maybe improving retention and treatment. Again, these nurses may not be available on site, but they're available through some kind of an agreement or affiliation. So just be mindful of that. The addiction specialist physicians, and I think, some of you may be wondering why that's noted here for level 1, but as noted in the text, there are going to be those cases that come up in level 1 that are more complex in nature. And so I think the ability to consult with a person who has experience and knowledge about substance use disorders is really important. They're important to at least have a relationship with, so that there's some way to access or consult with that addiction specialist physician or that physician with experience in treating substance use disorders. And then I did just put number 4 here because, and again, I'm not going to put this for all levels of care, but just wanted to, remind folks of the co-occurring capability requirements and making sure that program staff is really capable of interacting appropriately with these individuals who may have co-occurring issues or mental health conditions. Moving on to level 2.1, our IOP level of care. So for this level of care in particular, this is it's very, very critically important to have an interdisciplinary team. So that, when ASAM's talking about that interdisciplinary team, they're talking about addictions counselors, psychologists, social workers, physicians who have experience with substance use disorders. So that's that whole group kind of working together as a team, communicating with each other on a regular basis. Nothing is happening in a silo. Everybody is talking as a group and as a team. So this team of professionals, they're working together to provide that 9 to 19 hours of therapies for adults in this level of care. So again, it's not just the counselors that are providing these therapies, it's the other folks on the interdisciplinary team as well. It could be the nursing staff, it could be the physicians, it could be psychologists. So it's that whole group kind of working together to look at what the patient needs and then developing a plan of therapies that works for that individual to reduce their symptoms. For number 2 here for generalist physicians, so basically it's important to be able to provide a level of care that could maybe do physical exams for any kind of concurrent medical issues that the individual might be experiencing. So general medical care, this could be for things like hepatitis or HIV, other kind of co-occurring infectious diseases while that person is in level 2.1 treatment. So these programs, IOP programs, are really designed to provide comprehensive and integrated addiction and medical care at this level of intensity. And again, knowing that patients are available 9 to 19 hours per week for clinical activities, it's really important to have some kind of a setup where it's very easy for the patient to access these other medical services as well. It's a perfect setup for that. So just something to kind of be mindful of. Okay, moving into our partial hospitalization programs. So integrated care for this patient at this level of care is very critical because we're going to be seeing individuals at this level of care with more intense medical and psychiatric concerns. There might even be some issues with withdrawal. So really important, again, for integrated interdisciplinary care, communications, obviously of utmost importance. So same kind of thing here, interdisciplinary team of professionals. So that includes the psychologists, the counselors, the social workers, the physicians with experience in substance use disorders. So making sure that this team is working together to kind of create that individualized programming. And again, we all know that at this level of care, that includes 20 or more hours of therapies a week. Staff has got to be able to understand the uses of psychotropic medications and their interactions with substance use disorders. So again, providing that integrated care for those psychiatric, those medical issues, those possible issues with withdrawal. And I just want to take a moment here to bring up, so we had a previous, I think this may have occurred when we were having our co-occurring capable call, but when we brought up this idea of, counselors should be able to speak about, or they should be knowledgeable and should be able to speak with patients about, medications that are commonly used for mental health conditions. I think somebody brought up a concern about this, and maybe the concern, I think, was related to just making sure that the counselor was operating in their scope of practice. So just want to make sure that we're very clear. Absolutely, we are saying that nobody should ever operate outside their scope of practice. But I do just want to also point out that in a co-occurring capable system, in particular, and especially knowing that certified substance use disorder counselors or LPCs or social workers, they've all had training, in their training programs related to psychiatric medications and just mental health conditions. So again, we're never asking anybody to operate outside their scope of practice, but when we're talking about co-occurring capability, I mean, really counselors and SUD treatment programs, absolutely, it is appropriate for them to be talking very generally about psychiatric medications. Because I think, at the point where we're saying this is off limits, this is something that we can't talk about with the patient, I think the message that sends to the patient is really, really powerful. And I think that, having knowledge and education about common side effects, general uses of the medication, just psychoeducation, the benefits of medications. This is absolutely appropriate to be speaking about in a co-occurring capable system. And so obviously each program should have policies and procedures and be talking about training with staff about this, but it's absolutely appropriate, and counselors in an SUD treatment program should be comfortable and able to speak very generally about medications prescribed for mental health. So just wanted to bring that up today. Level 3.1. So in Pennsylvania, obviously, we all know this is a halfway house, and this is requiring 5 hours a week of skilled treatment services. And it also includes a 24-hour structure and support. So we know that individuals at this level of care require assistance in developing recovery skills and just being self-efficient. They may have lack of connection to their community, to work, to education, to family life, things like that. So just learning interpersonal skills, strengthening basic recovery skills. And as we look at the level 3.1 staff, that really does make sense. So making sure that there are allied staff, and in ASAM, when they say allied staff, they also kind of provided a very brief explanation. They said allied staff, which includes a counselor aide or group living workers. This probably would be techs. I think that's the common term in Pennsylvania. And so those individuals would be available. This allied direct care staff, they're a very important part of the program at level 3.1. They are the ones providing 24-hour support and monitoring of patients. Again, clinical staff understands the various aspects of substance use disorders, and they can also identify signs and symptoms of maybe an emerging mental health condition or symptoms that are intensifying for mental health conditions. And again, this team of appropriately trained professionals working together. If they're not on site at the 3.1 physical site, then they are off site, but they're all communicating. The communication is extremely important at this level of care because they may be separately physically kind of working apart from each other. So that is absolutely very important. And so I think that, again, when we're looking at 3.1 in particular, we also need to be mindful of that support systems backdrop that we talked about in previous calls, right? So making sure that telephone or in-person consultation with a physician is available 24 hours a day, 7 days a week. There's direct affiliation with other levels of care, higher or lower levels of care, direct affiliation with other programs that provide like literacy training and other social supports, ability to coordinate lab and toxicology testing, and making sure that there is a way for individuals to receive medication-assisted or pharmacotherapy for whatever needs they may need or whatever needs they may have treated. So just making sure, again, that we're looking at this in the support systems backdrop that we've talked about in previous calls. And then level 3.5 are residential levels of care. So we all know that level 3.5 programs are for individuals whose substance use disorder is really so unstable or so out of control that a 24-hour supportive treatment environment with daily clinical services is available. So folks at this level of care have significant issues in dimensions 4, 5, and 6. So there may be issues with severe kind of impulsivity, very kind of poor or low social skills. They might have a significant criminal history, just have very minimal coping skills, very minimal recovery skills, if any. So in addition to kind of what's listed here, physicians must always be available for consultation. And then making sure that, again, that the allied health staff is available 24 hours a day. So just like 3.1, allied health staff is really a critical part in this level of care, providing that 24-hour structure and that 24-hour support. The other thing that I want to say about level 3 is that the interdisciplinary team, just like any other level of care, is obviously very critical. So as we're moving up in the intensity in these levels of care, again, becomes even more critically important for the team to be communicating with one another. So physicians, allied health staff, nurses, counselors, everybody is talking with each other and communicating on a very regular basis. And it's really important that competencies should be established for each role within the team. So making sure that everybody is assigned to a certain task or tasks and everybody is aware of that. And again, programs will be, they already probably have developed policies and procedures around that. So I'm trying to think if there's anything else here. I think for level 3.5, the one thing that I really just want to point out here is that as we're, again, moving along to more intensive levels of care, that that everybody, again, is in close communication with one another, and that there is a regular flow of just dialogue between the various providers. Again, just like other levels of care, direct affiliations with higher and lower levels of care are available, in addition to laboratory toxicology services, things like that. Okay, so level 3.7, we know is a level of care for individuals with substantial issues in dimensions 1, 2, and 3. So it's, level 3.7, I think I mentioned this during our last call, is essentially 3.5 with a more intensive medical and nursing component. So again, we're having our interdisciplinary staff, including the physicians, the nurses, the counselors, the behavioral health specialist. Everybody is knowledgeable about the biological and psychosocial dimensions of substance use disorders. Now, for this level of care in particular, you note that a licensed physician to oversee the treatment process and to assure the quality of care. So this is unique to this level of care, and we haven't seen this in the previous levels of care. And then on 4, licensed physician or physician extender to prescribe addiction pharmacotherapies to provide that medication-assisted treatment. And I'm just going to stop here because I think I heard somebody, and I just want to make sure that they are not trying to say something here from licensing. I think we're okay. All right. So again, this level of care is unique in that there is a much larger role for the physician to oversee the treatment process to make sure everything is being provided in accordance with the highest quality of care. Because again, the individuals with this level of care are people with very significant potentially withdrawal, biomedical issues, psychiatric issues for 3.7. So moving on to our final level of care, level 4, the most intense level of care. So we all know patients at this level of care have severe issues in dimensions 1, 2, and 3. They require primary medical and nursing care. Treatment is provided 24 hours a day in a permanent facility with inpatient beds. The full resources of a general acute care or psychiatric hospital are available. So although the treatment here is specific to substance use disorders, the skills of the interdisciplinary team and the availability of other support services, so medical consultation for any specialty issues that the person may be experiencing, have to be coordinated and available. So again, in level 4, most of these resources and support systems are available on site. But if a patient needs something that's kind of above and beyond what's available, then that is easily coordinated. There's already kind of some kind of a partnership established as needed. So again, you can see the interdisciplinary team here, the physician coverage 24 hours a day, which, in an acute care hospital, we know that that's something that is readily available. Primary nursing care and observation 24 hours a day. And then addiction counselors are also providing services 16 hours a day, which is also a unique aspect of this level of care, is that higher level of daily services. Just making sure I'm not missing anything here. I think we covered everything for level 4. Okay. So those are the levels of care. Got through those with the staffing. And before I go into the questions and answers, I am just going to pause here to see if there's anything that I can answer before I go into the questions and answers. Okay, I am going to continue on with the questions and answers. So we did not get a lot of questions in on this specific topic, but in the past, we have gotten questions which is related to staffing. So we wanted to pull these up as just to make sure everybody was on the same page. And I thought this was an opportunity to make sure everybody understood certain aspects related to staffing. So required trainings for ASAM alignments. This is certainly a question that we have gotten very, very frequently. And so just going to kind of go through this today. And again, remember that these slides are available on our ASAM website, and they are available for viewing at a later date. So you can always pull this up. We can always answer additional questions that you might have, but just wanted to make sure that we discuss this today. So motivational interviewing training is recommended for all positions except for case managers. Clinical supervisors are recommended to take this course by July 1st of 2023, and other clinicians are recommended to take the course in 2026. So there's definitely a period of time there that allows people the ability to kind of get this done and to get this important training. Motivational interviewing is required for case managers per the Case Management and Clinical Services Manual, section 5.09. So that is motivational interviewing training. If people have questions about that, you can reach out via the ASAM resource account. Happy to answer any questions on that. In line with the idea that all levels of care must be co-occurring capable, co-occurring training is required for clinical supervisors by July 1st of 2022, and it's required for counselors and counselor assistants and case managers by 2023. So I don't think that's a surprise to anybody. We've talked about that for a while, but I think it makes sense in this idea of a system that is co-occurring capable across all levels of care, that everybody would receive at least this co-occurring training. And we know that most folks have actually received quite a bit of training above and beyond that. So just wanted to remind people. And then the ASAM 2-day training. So this is required for case managers, their supervisors, and all SCA contracted treatment provider staff and their supervisors. So that has not changed. That has always kind of been like that. And just wanted to put that up there so everybody, again, had a reminder about that. Just making sure I'm not missing any questions here. Okay. Going on to the next question. This question about licensing and credentialing or certification. So, okay, so in terms of who needs to be licensed and credentialed and by when. So before I dig into this, I just want to make sure that people understand that, you know, we're talking about this from an ASAM perspective today, but there are also, and most people on this call know this, there are also minimum requirements for counselors that are found in the regulations. So in 28 PA Code 704. So in addition to that, so case managers completing level of care assessments. So case managers completing level of care assessments, they must be licensed or certified or be working towards licensure or certification. Okay. Same thing for counselor assistants, counselors, and clinical supervisors hired after July 1st. So all these individuals must be licensed or certified or working towards licensure or certification. Now, for individuals who were working at that organization prior to July 1st, 2021, they are not subject to certification or licensure if they stay within that same position. So we've used the term grandfathering in the past to talk about this. And so just want to make sure that everybody is very clear on that. So again, case managers completing level of care assessments, counselor assistants, counselors, clinical supervisors, all must be licensed or certified or be working towards licensure or certification, and there must be documentation of that, which the employer is maintaining. So that hopefully that is clear to everybody at this point. I'm pretty sure that it is. If you have any questions, we're happy to answer those on the topic of licensure and certification. So this is another question that we've been getting a lot from folks. Does licensure or certification from another state count? So when you're looking, this is not so much ASAM related, but we've been getting this a lot into the ASAM account. So I am going to speak on it because I thought this was a good audience to talk about this with. So does licensure or certification from another state count? So if you look at the regulations, and I have the regulations listed here, it states, and I have the quotes here, full certification as an addictions counselor by a statewide certification body, which is a member of a national certification body or certification by another state's government's substance abuse counseling or certification board. So I, again, just want to refer folks to the regulations and what it says there. Does licensure or certification from another state count? Yes. But again, please refer to the regulations, and I have the link here for folks who need to have access to that. We are going to get into some questions here in a minute, but before we dig into the questions, I just want to, first of all, remind folks that, gosh, we're going to be in the month of July for our next call. So that July 4th, we're not going to be working. So happy 4th of July in advance to everybody. And we have not solidified the topic for the next technical assistance call. However, we're working on a few options right now. If you have suggestions on topics, please put those in the chat, or you can email those to the resource account. And just also want to remind folks about the various resources that we have available on the ASAM transition webpage, and I have the website listed there. Especially as we're getting into this alignment review process, please, please, please be reaching out if you have any questions or if you're just unsure of something. We are happy to set up a call with you and your team. That is what we are here for. So please reach out to us and let us know how we can help with anything related to ASAM alignment. Please reach out to us. We're happy to help. And I think that is all that I have here. And I also see that Jody Skiles put in the chat, if you need support or assistance, please ask Licensure, and she put the Licensure resource account in the chat as well.
And
all right. Yeah, Jody, go ahead.
Yeah, just to add that we look at resumes or at a credential. So when clarification, if someone is qualified as a full counselor, we will help you with that. So send that information to that RA account.
That is really helpful. Thank you, Jody. So I know, Jody, you were cutting up a little bit, so I'm just going to kind of restate that. Jody was basically stating that if you need help looking at somebody's resume to make sure that they do have the requirements necessary for the position of counselor, licensing is happy to assist you with that. They can help you look at that. And that is a great resource. So thank you, Jody. Okay, so what I'm going to do right now is I'm going to go through the chat here and see if there are any questions that I can answer while we're on the call, since we have about 15 minutes left. So just bear with me for a second. The other thing too is if you are on the call right now and if you want to raise your hand and ask a question live, you can certainly do that. So there's kind of a raise hand function at the top of your screen. If you also just wanted to do that, I can also pick on people that way. So while I'm looking here. Okay, so Jason Snyder asked a question, will each provider have one ASAM audit, or will a provider be subject to ASAM audits by each MCO and SCAs with which they contract? So Jason, I am not going to respond to that question because I do not believe that I know the answer to that. But if there is anybody on DDEP's side who is able to respond to that, I would just ask that you raise your hand and I can unmute you, or if anybody else is on the call, they can certainly do that. We will get back to you on that question, Jason. Jennifer Greenman asks, will there be tools that the providers will have access to that would be helpful to know what is being looked for? So before we dig into that one, I see Lynn Wright is raising her hand, so I am going to unmute you, Lynn, and I'm going to allow your mic. So Lynn, you should be able to unmute yourself right now.
Okay, I think can everyone hear me?
Yeah, we can.
Okay, so the plan is not to have every provider receive an alignment review by each different BIMCO. It's a joint effort, so the SCAs and the BIMCOs, as well as DHS and DDAP, are doing those jointly. The pilots are being done jointly, and then the plan is to have one alignment review, and then of course each BIMCO, will be doing their own separate quality reviews and that kind of stuff that they normally would do. But the plan is to have one alignment review.
Lynn, thank you so much. I appreciate you unmuting yourself and speaking to that. That was really helpful.
Sure.
So Jason, hopefully that was helpful to you in responding to that question. So I'm going to go back to my chat here. All right, so will there be tools that the providers will have access to that would be helpful to know what is being looked for? So Jennifer, great question. And Barbara, I see that you're raising your hand too, so I'll go to you next. So Jennifer, I would say the resources that I would encourage everybody to be taking a look at are, I mean, obviously the ASAM text and the specific level of care that you are providing and what's noted in the ASAM text is absolutely going to be critically important to be familiar with and looking at. On our ASAM transition website, we have level of care specific self-assessment checklists. And so I would definitely recommend that folks be taking a look at those. Those are a really, really helpful resource. They've already been up there for a while now. So if you haven't already accessed those for the specific level of care that you're providing, those are just a great way to kind of go down through staffing and therapies and support systems and documentation, and just, you know, kind of mark those off when you're thinking about your program and preparing for alignment reviews. If anybody else from DDAP or DHS has anything they want to add to that, please feel free to, but I definitely think those are the two most important resources, the ASAM text and then the resources available on the website. All right, so let me see here. Barbara, I am going to allow you to speak now, so you should be able to unmute yourself. Barbara, do you want to unmute yourself and speak?
Yes, can you hear me?
I can.
Oh, hi everybody. Okay, so two questions. If a person wants to get the LPC, but don't have the correct master's degree, is there somewhere that you can maybe get grandfathered in if you have the years experience and everything? That's part one. And part two of the question is that if a person has like 15 years of a counselor and is in a supervisor position, can she or he also perhaps be grandfathered in to see about getting their LPC as well? I'm not sure if you can. Does that make sense what I'm asking? Okay.
Yeah, thanks, Barbara. So I heard two kind of questions. I think for the first question, I am going to ask if anybody from licensing is able to speak to that. So my understanding of the question is if the person does not have the correct master's degree. And Barbara, are you asking, are they already an LPC or no?
No, they're not. They're not at all. They have a clinical supervisor position and they have years of experience, but their degree, master's, is not in it, but their undergrad is in the human services, psychology and sociology.
Okay, so Barbara, what I'm going to recommend is, I think this is exactly in line with what Jody was just speaking about. I would recommend that you reach out to the licensing email account that Jody put in the chat, because I think they can help you specifically with both of these questions.
Okay.
Yeah.
Okay, thank you.
You're welcome. All right, and I don't think anybody else is raising their hand right here. All right, so I'm going to go through at least a couple more questions and then we will wind this up here. Thank you everybody for your patience as I'm taking a look at these. Will the staffing, Betsy Duncan asked, will the staffing regulations be updated at level 1, 3.5, and 4 to reflect the certification is required for counseling staff? Will the staffing regulations be updated at level 1, 3.5, and 4? So I'm going to try to answer this, and if anybody else wants to add, please do that. I have no understanding or I have no information that there's going to be any updates to staffing regulations at this time. So that's the information that I have. If anybody else wants to speak to that, they certainly can. But I will say that the expectation with ASAM alignment and the requirement with ASAM alignment is that all counseling staff be licensed or certified or working towards licensure or certification unless they are kind of quote unquote grandfathered in. Going on. Jennifer Greenman, this is a great question, and I think that I would like to ask other participants feedback in responding to this question. So if you have an answer, please raise your hand. But Jennifer Greenman is asking, has any other rural provider had trouble having the appropriate members available for outpatient and intensive outpatient levels of care, especially in reference to the interdisciplinary team? Even finding the required medical director was difficult, let alone one with addiction experience and training. So Jennifer, great question. I'm going to open this up to see if other folks have any feedback or experience with this. If you do, please raise your hand. So again, just going to ask the group one more time if they're willing to answer. Barbara, I don't know if you're raising your hand again, but I am going to unmute you again.
I'm not.
Okay,
I'm not
got it.
raising my hand.
All right, Anita Robinson, I am going to unmute you. Just give me 1 second here. All right, Anita, you should be unmuted. You can speak.
Okay, thank you. We're an SCA and a functional unit with an outpatient and IOP program. What we've seen in our rural community, we have less than 90,000 individuals live in our county, that the various providers in our county tend to share the medical directors. So one medical director may work in 1 or 2 different counties at 2 or 3 different provider agencies, and we collaborate quite a bit, and it's been successful so far.
Thank you, Anita. I appreciate that. Anita, thanks again for speaking up. I appreciate that. And I'm going to kind of reach out to you on the side to see if I can connect the both of you, but thank you again for speaking up about that. All right. Yep. All right. I think we can get through one question. All right, so Tamara Williams, and I'm just kind of going through a couple right now. In terms of being co-occurring capable, any plans to train providers to better manage behavioral health crises? So Tamara, what I would say to that is that right now we are in the process of updating the co-occurring bulletin, DDAP and DHSR. And so I would say that there is going to be more information coming out along with that bulletin, but available right now is a co-occurring training that Dottie Farr and Kate Chichester are facilitating right now. And information about that co-occurring training is available on the DDAP training website. I would say I would highly recommend this updated training. This has a lot of very good resources and guidance related to co-occurring issues in terms of behavioral health crisis management and other things. And so please take a look at that on the DDAP training website. I think as we get prepared to kind of release this co-occurring bulletin, there will be more resources available at that time as well. But that's a great question. All right, yes, there is a difference, Jennifer Greenman, between co-occurring capable and co-occurring enhanced. And so that is discussed during the co-occurring capable training that we have available on the ASAM transition website. So I would recommend taking a look at the co-occurring capable training that we put on, or the monthly TA call that we put on, and it discusses the difference between co-occurring capable and co-occurring enhanced. Also, in the beginning of the ASAM text, I think it's like pages 21 through 27, it does discuss in detail the difference between co-occurring capable and co-occurring enhanced. And Gregory McConnell asked, are clinical technicians required to take motivational interviewing co-occurring in ASAM? So Gregory, I'm gonna pull up that slide for you again. Are techs required to take motivational interviewing co-occurring in ASAM? So Gregory, the positions that are covered by the trainings, motivational interviewing, co-occurring, and the ASAM training, those are required for case managers, their supervisors, clinical supervisors, counselors, and counselor assistants. Techs do not fall under that. So as long as the tech is in the role of a tech, then they would not be required to do that. If I'm speaking, somebody please let me know, and I'm happy to step aside there, but that's my understanding. I would say definitely a benefit to those folks getting those trainings, because it would be very helpful in interactions with individuals in substance use disorder treatment. All right, and I am going to stop right there. And there is just one last question. Is there an invite for the next meetings? Yes, there is an invite for the next meeting. If you do not have that invite, if you can please just email us at the ASAM resource account. And we can add you back onto that invite. We're happy to do that. So if you don't see an invite for next month's meeting, and again, the date for next month's meeting is Monday, July 11th, then please reach out to us and we will make sure that you are on that invite. Okay, everybody, thank you so much for being on the call today. For those questions I was not able to answer during the call, we will provide responses and we will put those on the ASAM transition website next to the topic of staffing today. So that probably will take us about a week to 2 weeks to put on there, but please know that your questions and our responses will be put on the ASAM transition website. Just give us a week or two to put those on there, and we appreciate everybody for joining us today. Jennifer is asking, I do have time for one more question. I was just joking. What will be required for co-occurring capable or co-occurring enhanced? So Jennifer, everybody is required to be co-occurring capable. Everybody is required to be co-occurring capable. If you are looking to be considered an enhanced provider, that's a contracting issue, and there's different requirements. But you can reach out to us about that. But right now, everybody is required to be co-occurring capable. All right, everybody, thank you so much for joining us today, and we will hopefully see you on next month's call.